Up to 80% of women develop uterine fibroids. For millions, these growths become a heavy, creeping burden of pain and bleeding, disrupting daily life. But when patients look for answers, they usually hit a wall. Standard medical advice often corners them into a frustrating binary choice: wait until it gets unbearable or undergo major surgery. On one end of the spectrum is watchful waiting. Doctors will prescribe iron pills for the anemia and birth control to manage the bleeding. But this does nothing to shrink the physical size of the fibroid, leaving women to endure pelvic pressure, suffer through constant severe bloating, and frequent trips to the bathroom. On the opposite extreme is a hysterectomy. It guarantees the fibroids will never return, but the cost is severe. Major surgical incisions, a forced 6-week physical recovery, and the permanent loss of an organ. This chart maps standard options, physical invasiveness on the x-axis against efficacy on the y-axis. Watchful waiting sits at the bottom left, low impact, low reward. Hysterectomy sits at the top right, highly effective but highly invasive. You do not have to accept these extremes. There are targeted middle ground options available. The first is uterine artery embolization, or UAE. It locks into the top left quadrant, offering high clinical efficacy with low invasiveness. Then there is the holistic route, a high-dose vitamin D protocol. This sits extremely low on the invasiveness axis, though its efficacy varies widely depending on strict daily adherence. Choosing a path involves mapping the biological reality of these specific treatments against your own life stage and your personal threshold for recovery. Fibroids thrive on estrogen. It acts as their primary growth hormone, creating a dense, inflamed, and low oxygen environment within the uterus where these muscular tumors can rapidly expand. Vitamin D functions as a metabolic brake pad for that growth. It regulates the estrogen receptors directly and downregulates an enzyme called aromatase, which converts other hormones into excess estrogen. To affect a dense fibroid, a standard daily multivitamin will not work. The protocol requires massive doses, often between 25,000 to 50,000 IUS of vitamin D3 taken frequently, which is far above standard medical guidelines. Consuming doses this high introduces a risk of excess calcium in the blood, leading to kidney stones. To prevent toxicity, patients must follow strict guardrails, taking magnesium, vitamin K2, and drinking at least 2.5 liters of water every single day. The goal is to trigger apoptosis. At the cellular level, this forces the irregular fibroid cells to essentially commit suicide, breaking apart and slowly dissolving into the surrounding fluid. Several clinical trials show significant fibroid shrinkage using these high-dose methods. Yet many standard OB/GYNs remain highly skeptical, routinely discouraging the practice due to fears of that potential toxicity. The primary trade-off here is time and discipline. You are avoiding a hospital room, but you must commit to a rigorous daily routine for several months before seeing any meaningful relief from heavy bleeding or pelvic pressure. This holistic route targets the root metabolic causes of the growths. It trades immediate definitive relief for a long-term lifestyle overhaul. For those needing faster clinical relief, uterine artery embolization is an outpatient procedure performed by an interventional radiologist in an angiography suite. Rather than cutting into the abdomen, the doctor accesses the vascular system through a simple pinhole-sized entry site in the radial artery of your wrist. Looking at this anatomical map, we can trace the path of a tiny catheter threaded from the wrist down into the pelvis, eventually reaching the uterine arteries that feed the round fibroid masses. Once in place, the radiologist injects microscopic particles. As these blockages lock in, blood flow to the fibroids is shut down, causing them to turn gray and die. The surrounding uterus remains vibrant and alive by drawing blood from other collateral pelvic vessels. The clinical results are highly consistent. UAE resolves heavy bleeding in roughly 90% of patients. and eliminates bulk symptoms like pelvic pain and frequent urination in 80 to 90% of cases. The bleeding stops quickly, but total volumetric shrinkage of 40 to 70% typically takes about 6 months to fully realize. The main physiological trade-off of UAE is dealing with the aftermath. You avoid a major surgical incision, but the dead necrotic fibroid tissue remains inside your body where your system must slowly break it down and absorb it. UAE delivers a whole uterus solution for widespread fibroids, trading the surgeon's scalpel for a highly targeted ischemic attack. You will often hear this procedure marketed as minimally invasive. While you do avoid a hospital stay, that does not mean the recovery is easy or painless. When the blood supply is cut off, the ischemic death of the fibroid tissue causes severe expected pelvic cramping that peaks shortly after you go home. Surviving the first 48 hours requires a heavy chemical regimen. Patients rely on constant heating pads, prescription strength 800 milligram Motrin every 6 hours, and a steady rotation of strong narcotics to sleep through the worst of the pain. Relying on those narcotics creates an immediate secondary crisis. They are powerful pain relievers, but they also severely paralyze the digestive tract, setting you up for agonizing constipation. Because of this, an aggressive bowel management protocol is mandatory. You must take stool softeners, push laxatives like magnesium citrate, and drink massive amounts of electrolyte fluids to force your system to keep moving. By the second day, you have to transition from bed rest to forced movement. Walking around the house is critical to stimulate your bowels and prevent blood clots from forming. This timeline plots the first 7 days of recovery. Notice how the red pain line spikes drastically on days 1 and 2 before plummeting, while the blue mobility line steadily rises. By the end of 1 week, most women are back to their normal daily activities. UAE trades a 6-week physical recovery for 48 hours of intense, actively managed physiological stress. This decision tree helps map the severity of your symptoms against your future life goals. The starting node asks for your primary treatment priority, branching out into 3 distinct paths. The first path highlights a patient with mild to moderate symptoms or underlying conditions like PCOS, who wants to address the root cause and avoid synthetic hormones or medical procedures entirely. Following this branch leads directly to the high-dose vitamin D protocol. It is highly effective for this profile, provided the patient maintains strict daily compliance and secures medical supervision to monitor for toxicity. The second path moves to a patient suffering from severe bulk or bleeding who is finished having children and absolutely cannot afford a 6-week surgical downtime away from her career. For this profile, a 90% clinical satisfaction rate and 1 week off work is a favorable trade-off against 6 weeks of surgical downtime, even with the intense recovery requirements. The final path focuses on the patient with life-altering symptoms who still actively desires to carry a future pregnancy. This branch ends with a clear warning: proceed with caution. This patient must prioritize a dual consultation, speaking to both an interventional radiologist and a gynecologist to weigh UAE against a surgical removal of just the fibroids. There is a critical nuance for this profile. While many successful pregnancies are documented after UAE, there is limited clinical data on how embolization affects the long-term viability of the uterine blood supply as a fetus develops. Traditional medical consensus often lags behind the available technology. Patients are frequently forced to proactively advocate for their specific life stage needs when sitting in the examination room. You should never let a doctor push you into a hysterectomy without thoroughly exploring these targeted middle ground options first. It is your uterus, your timeline, and your choice.